Have you. Thank you.
Thank you. It's a pleasure to be here, and thanks to the organizers for the opportunity of presenting on this topic. I'm going to take a slightly different take on this issue, analyzing the issue of community-based service for newborn health in terms of the context of Bangladesh, using that, what is happening there, and what are the particular challenges here. Particularly start off with presenting what has been changing and in terms of progress that we are making in Bangladesh, and also taking an example from one operations research we were doing around maternal, around neonatal sepsis to illustrate the particular challenges that we're facing in Bangladesh. Just with a bit of background, yes. Okay, this is table just summarize the early studies or the real studies that basically established the need for approaching the issue of neonatal health and survival based using a largely focused community-based intervention. These are studies primarily from South Asia that established this consensus amongst all of us that there's something can be done and should be done. This led to this joint statement in 2009 from WHO-UNICEF that established the need for home-based care, and particularly one particular specific recommendation that came out of that was the need to visit babies who are born at home as soon as possible within after birth in one day, and again on day 3 as well, with very specific services and tasks to do. And this particular statement has driven programs across the country, across the world, and particularly Bangladesh. We have been guided by this in terms of designing our programs, our strategies, and about the same year, our own national neonatal health strategy came about, and which particularly incorporated many of the things that have been emerging from the global evidence base, with a very strong focus on community-based interventions. So what has been achieving, what progress have we made in Bangladesh with newborn care and also related maternal health interventions? One key issue is that affects both mothers and newborns is skilled attendance and delivery. It has been increasing fairly rapidly. It is still low at 32%. But what is interesting is the contribution of facilities, particularly private facilities in this increase, which is quite like in last DHS, which came out this last year, 17% of the 32%, more than half of all delivery skill attendance is in facilities. And this facility delivery is driving the postnatal care of newborns. Almost none of the postnatal care is happening outside facility deliveries. So babies who are being born at home, which are the vast majority, are not really receiving postnatal care. But we are making progress elsewhere with essential newborn care practices. Things have been improving in general with almost all the indicators that we are tracking. The worry is the last set of bars, which is 0% and 2%. That is the number of babies who receive all essential cares in the same child. And that's where we are really not making a headway at all. Even though individual indicators are increasing, the number of babies that receive all care is not really anywhere near, something to even talk about. The country has been investing in training community health workers on essential newborn care. It has trained 67,000 workers. This map shows the density distribution of these workers, with the highest density up north in Rangpur division, particularly attributable to BRAC, and also in Dhaka. And then you have the large orange areas where density is much less. But how has that translated into actual coverage? This is slightly old data, so it may not reflect all the training, but from the Maternal Mortality Survey 2010, less than 6% of homeborn newborns in Bangladesh received postnatal care within 2 days of birth from a community health worker or a medically trained provider. And most of that actually is from non-CHWs. However, there are special program areas which now cover almost half of the country, and this is one example of the MNCS special programs supported by government and UNICEF that ended last year in 7 of 64 districts, where 45% of home births are getting this home visit within 2 days. So it is possible to achieve high coverage with this, but these are special program areas which are with its own challenges of sustainability and scale up as well. We have, right now, these programs cover half of the country. In terms of the continuum of care issues, the way I've looked at it is not only because in terms across service levels, but also across, the life stages as well, pre-pregnancy, pregnancy, labor, delivery, and newborn pairs. And we have to worry about both, and they intersect quite interestingly. The reason we saw one slide before in terms of that, where we saw only 2% of all newborns receiving all interventions. This is under more controlled conditions, as part from the data from the Pajama studies and SELECT, which shows that it is possible under controlled conditions to achieve fairly high coverage of some of the most essential interventions. What you'll note also, most of these interventions are things that can be delivered quite effectively at the home or in the communities. If you move on to the real world and also to services that also require more complicated institutions, then we struggle there. This is antenatal care, delivery care, and postnatal care from the maternal mortality survey. And individually they're not very great, but what is interesting is that only 19% of the women actually receive all of the care that we are recommending. So we are having troubles providing continuum of care both across services levels as well as across the life stages. And now I move on to this one example of looking at how do we manage neonatal infections in Bangladesh, and the data that we just getting from an operations research project that we just finished. On the background is that we really do not have a lot of data in terms of nationally coverage of neonatal infection management. The continuous debate that we're having in the country is about who would be best placed to provide that care. Is it the community health worker? Is it the community clinics, which are a new level of facilities being established right now? Or is it a slightly higher up union level facilities that serve a population of over 20,000, community clinics serve a population of over 6,000? And we can't just think of that in isolation without thinking about referral facilities and how can we establish and sustain quality of care in referral facilities, which are the Upazila health complexes or the sub-district hospitals. So in the neonatal health strategy, we made specific recommendations on the need to look at community-based operational research on neonatal sepsis to guide the program design. And this was back in 2009. We were able to get started with the project in 2011, mid-2011, and we had an 18-month project. Aim was to look at the quality and coverage of different approaches to community case management of neonatal infections. We adopted a cluster randomized design. It was nested in the WHO-UNICEF MNCS program. 10 unions. Unions is the lowest administrative unit, covering about population 20,000 to 25,000, randomized into kind of intervention and comparison units. And everywhere we had the MNCS service package was there. In the 10 intervention unions, we added on the neonatal case management, which included basically training of 3 different cadres of workers on newborn case management, neonatal infection case management. Government health workers, HNWAs, who were operating out of the community clinics, the MNCS promoters, who were specific volunteers recruited for the MNCS program, and the village doctor, the informal providers. During 18 months, each of the study areas had a coverage of about 7,000 live births, and this was spread over 4 districts in 4 sub-districts in 3 districts, covering a population of about 400,000. And the intervention included training of service providers and program management support. We wanted to make it as real as possible without overly being interventionist. This management support was through existing government systems with support from the MNCS NGO on site and ICDDRB. The support was primarily supplies, logistics, and supervision monitoring. A total of 492 health workers were trained, 79 government health workers, 213 MNCS promoters, 200 village doctors. We established reporting systems for all 3 cadres of workers. However, only 118 reported at least 1 case of sepsis being treated by them or referred by them. So most of these providers did not even report over a period of 18 months a single neonatal sepsis case. Then we had a reported about 223, of which we were able to trace back 162, which is about 2%. So it was quite depressing in terms of what was reported. In terms of what was happening, 59 out of 162 were locally managed, but very few were given injections, which was the treatment of choice was injection gentamicin and amoxicillin. So they were not receiving even the full treatment. And then the remaining 103 were referred to mostly to hospitals. But however, compliance with referral was pretty low. If you look at, we also had a household survey that showed us some interesting results. The household survey by nature has more sensitive definition of sepsis. We picked up about 1,400 cases in each arm. The most common provider was the informal providers, even though we saw just a while that they were not reporting at all. Then the local health facilities were pretty low down. You also had the doctors and the homeopaths as the primary providers. So even though we had, and there was very little difference between interventions and comparisons. So the question for us here is, where do we go from here? And I'm going to take just a minute to finish my remaining slides. In order for us to go from here, we have to make some choices. And just to give you a sense of the context, we had 2 progeromal studies. In Select up north, we had weak health systems. Referral care was low. It went from a low of 7% to 20%. Down the middle of Bangladesh, with strong health facilities, seeking care from referral facilities was pretty high, almost 50%. So the strength of quality of facilities has an influence on the percentage of people willing to go and seek care. The other side of Bangladesh is that we are very densely populated. We are way beyond anybody around us. This is the 100 million club of countries. We are 2.5 times more densely populated than Japan and India. So we are very densely packed. Distances are less of an issue. And that shows up here, where we see that between the 2 maternal mortality surveys, the reachability of a facility within 1 hour increased substantially, particularly private facilities. Was it because of greater numbers of facilities? Maybe, but mostly because investments have been made in transportations. So based on this, what are the choices we have to make? Last 2 slides. We have had trouble going to scale with home-based care and services, and gains in coverage have been mixed. We believe that Bangladesh needs its own model of a community-based care, taking into account the population density, the increased access to health services, the influence of health service strength and quality and utilization, the increasing investments in closer-to-home facilities being made right now, as well as advanced care services being made. These provide opportunities. So what would this model look like? We need to have greater reliance on strategically located, accessible, linked health facilities, things that Steve has talked about, but also being able to provide continuum care across different levels, life stages, across services, through package services, and advanced care. The role of community health workers, we think, should be more specific and time limited. Changing community norms in terms of maternal newborn care practices, emphasis on educating and empowering families and communities with skills and information, this last slide, and helping communities to more closely, effectively link to health services. This would be something that we think of could happen for most of the country, but there are certain hard-to-reach areas that will definitely require special programs, which we don't have at this time. Thank you.